Dr. Rama Murthy. I'm a radiologist into fetal medicine. I work out of Srinivas Ultrasound Scanning Center, Bangalore, India. In this webinar, hosted by LifeCell Diagnostics, we shall discuss fetal brain anomalies. How do we actually recognize them using the powerful tool of imaging? What are the genetics behind these abnormalities? And having known the anatomical problem and the genetic background, how do we counsel our patients? What is the fallout which we need to share with the couple? So the best way to do this is to look at case scenarios. These are worked up cases, and we will look at it from the imaging point of view because I'm a radiologist. I start with images, and then I'll take you on to the genetic aspect and perhaps the clinical aspect, but those will be what I have accrued over years of practice. So let's get started. Can we go to the slides, please? Yes. Okay, now let's look at this slide. This is interesting because it helps us to understand the number of specialists that are involved in sorting out or solving a particular problem in the brain, or for that matter, any other system in the fetus. Now, basically, it's a square. You have a radiologist who's involved in imaging prenatally as well as postnatally. You also have a geneticist who is involved prenatally or postnatally or even both to look at the genetic aspect. You have the neonatologist, pediatrician, and the pediatric neuro consultant who's going to be the clinician involved. You could involve the specialist prenatally or postnatally. And lastly, you have the pathologist who definitely comes in postnatal or post-abortal. So they are going to handle the brain per se in terms of gross anatomy and in terms of histopathology. Now, each of these specialists have their own perspectives, and each of them should also know the limits and the scope of what the other specialists can do. And therefore, convergence of all these expertise of all these four specialties would actually work towards the proper diagnosis, proper genetic diagnosis, anatomical diagnosis, as well as counseling. Now let's look at their roles quickly. Now what about the geneticist? First of all, understanding of genetic basis, that is their forte. They know what is the genetic basis. How does the phenotype correlate with the genotype? Are there tests, genetic tests available to solve this problem, the particular problem? What is the accessibility of such a genetic testing? How to choose the appropriate test? And most importantly, interpretation and counseling. Of course, you could do this prenatally or even postnatally after birth. What about the radiologist? The radiologist should have equipment which can deliver A-grade images on your monitor. You should have expertise. The radiologist should have expertise to actually produce those images on the monitor, understand fetal brain anatomy in terms of gross anatomy as well as ultrasound anatomy or MRI anatomy, understanding pathological anatomy. How does a picture, whatever section it is, whatever modality it is, how does it differ from normality? And having put together all the abnormalities that have been picked up on these images, have a differential diagnosis in mind, get up to the final diagnosis, and also have a good insight into what is the natural history of the abnormality. Now, what about the neuro consultant? The neuro consultant is the person who's actually going to explain to the couple as to what a particular disease in the fetus or a particular abnormality in the fetus, how does that translate into clinical symptomatology post-birth? So therefore, the couple gets to know that this is the anomaly which has been diagnosed in utero, and this anomaly could present as A, B, C, and D at this stage of fetal life, at this stage of postnatal life, so that they know the gravity of the problem. So that could be done by a pediatric neurologist or by a pediatric neurosurgeon, depending upon the exact nature of the problem. Again, genotype, phenotype, clinical correlation comes in over here, and they are the best people to advise on the morbidity. That's the symptomatology, that's the signs which come up postnatally, and also the mortality. And lastly, what are the therapeutic options that are open to mitigate this disorder? Lastly, the expertise of pathologists. So they are the ones who are going to handle the brain once it is given to them in terms of a fetal brain, if it's if it's a termination of pregnancy, or a neonatal brain if it's been a demise after birth. So gross pathology, histopathology, differential diagnosis, and final diagnosis expertise is very, very important. And today you have a genre of pathologists who deal only with the brain, and they are neuropathologists. So with this basic background, let's go on to the cases, and we will try and look at the findings first, because that's how I start. I'm a radiologist, and when a case comes up and walks into my center, I'm going to see this fetus as a set of images, and therefore we will look at the images first. Now, the first case scenario which I'm going to flash now is a 32-year-old, 28 weeks. She's a primee. There's history of third-degree consanguinity, which is first cousins who are married. The parents basically are normal. The 21 weeks ultrasound study, which I have done myself, was normal. So now, remember, she is 28 weeks. Now, by 28 weeks, I'm showing you an array of pictures of ultrasound, fetal ultrasound lined up above, and the corresponding pictures of the same planes on MRI below. Now, at 28 weeks, I need to see a lot of sulcation and gyration which has occurred. Now, how do this is an axial image. What sense do I make out of it? One, I look at the parieto-occipital sulcus region, and I find that there's hardly any parieto-occipital sulcus, right? Now, I look at the lateral fissure or the sylvian fissure region, and I realize that it's absolutely shallow. You can recognize that both on ultrasound as also the MRI, which was done post-ultrasound for correlation of the ultrasound findings. On the axial image, again, the CSP looks a tad narrower than what you expect it to be. This is the coronal image, again, a shallow lateral fissure there. This is the interhemispheric fissure. You don't see a cingulate sulcus. A small CSP there. Open, shallow lateral fissures that you see here. Now, this is a transcerebellar section, coronal section that you see here. That's the cerebellum. This is the tentorium, and you see the occipital horns there. Now, here you expect to see a nicely formed calcarine sulcus, and that calcarine sulcus is missing out here on ultrasound as well as on the MR pictures. You see the interhemispheric fissure, you see the cerebellum, but you see no trace of the calcarine fissure. So therefore, clearly it's a calcarine sulcus. So therefore, clearly this 28-weeker presents to you with delayed sulcation, and you, for the first time, you realize that this is an abnormal brain. You send out the lady out for a fetal MRI, and I've shown you the fetal MRI pictures. To continue the story, neurosonogram is not only axial sections. You've seen a coronal section already, and this is a mid-sagittal section. And on the mid-sagittal section, you see that the corpus callosum is seen in its entirety, both on ultrasound as well as on MRI. You needed to see a line here depicting the cingulate sulcus parallel to the corpus callosum, and that is actually not forthcoming at all. That's not forthcoming at all. On the parasagittal view or the three-horn view, you see that the cerebral convexity here is very nicely depicted. That's the subarachnoid space. This is the cerebral convexity, and the cerebral convexity is absolutely characterless. There are no sulci out here. By 26 weeks, I should see the convexity sulci, but that is not forthcoming. That is not forthcoming also on the MRI. So clearly, here we have a diagnosis of lissencephaly or delayed sulcation. Now, once there's a diagnosis of a serious abnormality like this, we need to have the genetic background, and the best thing to do is to collect a bit of amniotic fluid. You can see the needle in situ, that's the needle tip that you have there, and send out this amniotic fluid for clinical exome sequencing, and also a bit of the maternal blood out for maternal cell contamination. So that's exactly what was done, and when we got around the results, the sample was negative for maternal cell contamination, which means that the amniocentesis worked. The fluid which we have given is representative of the fetus and is uncontaminated by maternal tissue. Now look at the diagnosis. The clinical diagnosis, symptoms in history: fetus of so-and-so born of consanguineous marriage is suspected to be affected with lissencephaly. The ultrasonogram and the MRI of the fetus was suggestive of poor sulcation or operculation, consistent with delayed cortical development. Fetus of so-and-so has been evaluated for pathogenic gene variations. The result is a red band, which tells us that there is a pathogenic variant which is causative of the reported phenotype that was identified. Now, the phenotype that we've suspected or diagnosed is delayed cortical development, is delayed sulcation, lissencephaly. And what is the gene that has been found to be abnormal? This is the PAFA1B1 gene. It's located on exon 6, and that's the variant in both in terms of the loci as well as in terms of the amino acids which get flipped over, and that is the zygosity. So it's heterozygous, and when a gene in its heterozygous form, a single dose form, manifests as a disorder, as a phenotypic disorder, that becomes an autosomal dominant gene, and that's clearly enunciated here, autosomal dominant, and it's related to lissencephaly 1 or the classical lissencephaly, and it's classified as pathogenic, again shown to you in red. So it's a pathogenic variant. No other variants of uncertain or certain significance were actually identified. Now, what is a variant? A variant is a change in a gene. Now, a variant could be pathogenic, could be likely pathogenic, or could be a variant of uncertain significance. Now, in our case, if I were to go back, it is a pathogenic variant, which means a disease causing a variation in the gene which can explain the patient's symptoms. The patient for us here is the fetus now, has been detected. This usually means that the suspected disorder for which the testing has been requested has been confirmed. So therefore, unequivocally, this test is pathogenic variant, which means that the PAFA1B1 gene is the gene which is caused the lissencephaly. On the other hand, if it's likely pathogenic, it means a variant which is very likely to contribute to the development of the disease. However, the scientific evidence currently is insufficient to prove this conclusively. Additional evidence is expected to confirm the assertion of pathogenicity. So pathogenic, you're very sure. likely pathogenic, there could be a relation, you're not sure, and a variant of uncertain significance is a variant has been detected, but it is difficult to classify it as either pathogenic or benign, either disease causing or non-disease causing. So therefore, it's extremely important that we know that certain genes express as certain phenotypes, and that is a genetic database which is continuously getting upgraded, and that is where the geneticist plays a very, very pivotal role in interpreting these reports. Also, in the same report, you see the number of genetic loci which has been covered, which are actually related to the suspected problem. So you have about 18-20 genes which have been covered in this particular study. Now, you go to OMEN and you punch in PAFA gene, and you have the alternate names which are popping off, and one of them is the LIS1 gene or the lissencephaly 1 gene. So we know that the PAFA gene, platelet activating factor acetyl hydrolase isoform 1B, it all goes over our heads. We only have to remember PAFA, and we know that this is also called LIS1 gene. Now, how do we translate it or counsel to the couple? Now, it's an autosomal dominant, single dose, heterozygous. So therefore, you're dealing with a vertical transmission. When you're dealing with vertical transmission, you certainly have the idea that one of the parents is a carrier of the abnormal gene, and therefore that gene has come down into this fetus. But here, I have told you that the parents are normal. None of them have got any brain problem, least of all a lissencephaly problem. And therefore, where did this lissencephaly gene find its way into in an autosomal dominant form? The answer is, majority of LIS1 mutations are de novo. That means they are not inherited from a parent, and therefore the recurrence is generally low. And this is an important bit of information that we've got to share with the couple. Remember, this couple, this lady is a primey. They are certainly going to plan a family after they have gotten over with this pregnancy. So therefore, this would be the proper way of counseling. However, in some cases, a parent harbors a balanced translocation involving the LIS1 gene, and so their risk of recurrence could be much higher. So in some cases, yes, there could be a balanced translocation involving the LIS1 gene, and that can make this couple more prone to have a recurrence, right? Now here, I'm asking you a question. Is the third degree consanguinity important? We've realized that this is a third degree consanguineous couple. Is this important? No, it's not. Consanguinity is really not important in autosomal dominant, and it's not even here. We realize it's important, of course, before we go on, it's important in autosomal recessive because there are two genes which come in single dose. So if the fetus has a double dose, both the alleles are abnormal, and then this autosomal recessive disorder gets manifest. In autosomal dominant, it's a single allele, single gene mutation when present in a single dose is enough. But we now know that this is autosomal dominant, third degree consanguinity, really, really not important. Now let's go on to a little bit of genetics of classical lissencephaly. We know we have the autosomal dominant situation represented by LIS1 gene as what we saw in the case illustrated just now. You can have it in TUB, TAB-A1 gene. These are autosomal dominant, which works on the same way. Most of them are de novo, but if there is a balanced translocation involving the LIS1 gene, then there's an increased risk of the recurrence in the future pregnancies. You also have the X-linked dominant genes, which are DX, example, the double cotton X gene or the ARX gene. Now, X-linked dominant is a different ballgame altogether. Now, these diseases are manifest in their full force if the fetus or if the individual is male, because a male has only one X. That is if that X is abnormal, derived from the mother who is a carrier. The Y doesn't have power to counter this X, and therefore the disease is manifest in its full form. Whereas if the fetus is female, then the female has two X's, the other X is normal, so therefore the disease is not muted down, and therefore it's important to know the sex of the fetus in these conditions. Lastly, you have some genes which work on an autosomal recessive basis, where of course consanguinity is important, and where of course the recurrence rate is going to be absolutely high. It's 25%. So 1 in 4 subsequent pregnancies are going to be affected. Now, a little more genetics is very, very relevant over here. If the LIS1 gene is abnormal, and also the contiguous genes on either side are abnormal, if there are deletion of these genes, you get what is known as a Miller-Dieter syndrome. So LIS1 alone is classical lissencephaly, but when it is associated with contiguous genes which are deleted or abnormal, you get what is known as a Miller-Dieter syndrome. Now, the Miller-Dieter syndrome is oftentimes associated with facial abnormalities in the fetus. That means I need to look at the face. Whenever I see a classical lissencephaly, immediately I need to look at the face in terms of abnormal faces that I would expect if it's a Miller-Dieter syndrome, right? And of course, these are the DCX-linked mutations. As I told you, it's muted down in females as the double cortex on MRI, and cognitive delays. It doesn't present like a classical lissencephaly, but in males, you have a classical lissencephaly. In ARX mutation, you have to look at the genitalia, because this mutation causes lissencephaly plus an ambiguous genitalia. So the moral of the story is I'm going to look at genitalia again, not only male, female, but look for ambiguity in the genitalia. There's also a mutation called CRAD mutation, where there's lissencephaly associated with microcephaly. Now, how does this translate into postnatal manifestations of this disease? So the smooth brain means absent gyri and sulci, and it is associated with profound MR, severe epilepsy, microcephaly, so on and so forth. And therefore, this is where the Neuro Consultant would come into play and explain to the couple the gravity of the situation and the clinical consequences that one should be expecting. So here's a pop-in that I'm showing you. And as an imaging person, I would, in a case of classical lissencephaly or delayed sulcation, I would be critically examining the cranial size, looking for microcephaly or macrocephaly. The cerebellar size, we'll come to this later when we look at tubulinopathies, and I'm going to look at the face and the perineum to look at the genitalia. Now, when I said if there is classical lissencephaly and if the neighboring genes contiguous with the LIS1 gene are also abnormal in terms of a deletion or a mutation, you not only have the classical lissencephaly and the clinical features associated thereof, you also have facial abnormalities, you also have digital abnormalities, genital abnormalities, and congenital heart disease. And let's look at a case scenario. Here is a second gravida. She has lost her first child to a neurological disorder, which was similar. I'm not going to take you through that case for the paucity of time, but let's look at the current pregnancy, her 26-weeker, and just flashing the axial image. From a mile away, you know that the cortex is echogenic. It is thin. There is a increased subarachnoid space that you see here at 26 weeks. This is shallow. From a mile away, this is shallow. This lateral fissure is telling me the brain looks like about 20 weeks and not 26 weeks. Here is the parieto-occipital sulcus region. Again, nothing forthcoming out over here. And of course, you will see that if I look at the outline of the brain as such, it mimics a figure of 8, and I've drawn it for you there. That's the figure of 8 that you see. So a thin cortex, a hyperechoic cortex, figure of 8, and a profusion or increased subarachnoid space. Everything telling me that this is again another case of lissencephaly. Now, when I look into the face of this case, the orbits are prominent. So that's proptosis. They are set apart from each other, which means they are more distant from each other, which means that there is hypertelorism. When I look into the mouth on the sagittal, mid-sagittal section, that's the upper lip, that's the lower lip, and you know that the tongue is sticking out and it's persistently there. So that's a macroglossia. That's the outline of the fetal face. That's a small nose. That's the mouth, which is agape. And that's the fetus showing you the proptosis, the hypertelorism, a small nose which is upturned, an arched upper lip, and you can see the tongue sticking out. So that's macroglossia. So there is, in this case, a classical lissencephaly plus facial problems, which means that you're dealing with Miller-Dieker syndrome, which is a variant of classical lissencephaly. And you have fish probes. You can do it either by fish, Miller-Dieker probe, or you can do it with your clinical exome sequencing or next-gen sequencing to make out the genetic loci. So lissencephaly-associated genes may be related to the tubulin genes. We look at this a little later. May be related to microtubule-associated proteins, and this is the group that we saw just now. LIS1 forms a part of this group. It could be due to the CRAD genes, it could be due to actin isoform genes. Now, here is a beautiful slide I stumbled upon, and that's the reference I'm giving you. Shows you the anatomical departure from normal. Diffuse agiria, subcortical heterotopia, pachygyria, agyria. That's the anatomical, gross anatomical features which are listed here, and how these features are related to further qualification, whether there's a cerebellar dysplasia, whether there's an anterior hemisphere dominance, posterior hemisphere dominance, and how by a combination of this and this, you can actually predict what gene you're expecting to be abnormal. So once you get into that level of working, in terms of working, you can also discuss with your geneticist and tell him or her as to what exactly is playing on in your mind and what genes are you expecting to be abnormal. Now, if you look at lissencephaly as a whole pool of cases, you will see that classical lissencephaly, which we discussed, that was a case scenario that I put up a little while before. Classical lissencephaly and the Miller-Dieker variant, which means your LIS1 gene, your DCX1 gene, your ARX gene, the Renin gene, so on and so forth, pool in to contribute about 75%. Your tubulinopathies, which we will see a little more in the coming slides, contribute about 4%, and variant lissencephalies will contribute about 21%. So that is the other group which form the 21% over here. Right? So this group which forms about 21%. Now let's look at some more case scenarios. Now here's again a 26 weeks, and to cut a long story short, there are all signs of classical lissencephaly. I'm not going to repeat it because it's the same. Any classical lissencephaly would be the same as any other classical lissencephaly. But note, I'm showing you only cases at 26 weeks because that is the time frame I need for a certain stage of development of the brain to occur. If I were to see it at 21, 22 weeks, my interpretation of whether the sulci, the lateral fissure, are normal or abnormal becomes very difficult. But at 26 weeks, my job is a lot more easier. So 26 weeks, again classical lissencephaly that you see here, but in addition, you have the posterior fossa, which is throwing out a finding, and that is a small cerebellum. You also have that cerebellar hypoplasia. You also have contractures in both the upper limbs. You can see the wrist there, you can see the flexion of the wrist, and you can see the extension of the metacarpophalangeal joints. Those are the MRI pictures, again telling you that it's a classical dysencephaly scenario. That's the hypoplastic cerebellum that the MRI has also confirmed. And when you look at the fetus real time, you find that the limbs go into fits. You're actually looking at tonic-clonic jerks in the fetus, which is telling you that this fetus is already having an epileptic seizure in utero, right? So that is one case scenario. Before I go to the genetic basis, let us look at another case scenario. Here is a 23 years, 19 plus weeks, G3AB2, referred for lateral ventriculomegaly. No marks given. From a mile away, you know that this is frank ventriculomegaly. This is 19 weeks. This is a transabdominal ultrasound. Now, when I look at the posterior fossa, those are the dilated ventricles. That's the dangling choroid sign. And when I look at the posterior fossa, you see that this cerebellum again is very small. TCD of 1.4 at 19 weeks will translate into less than 5th centile. So you want to see this brain better. So I'm going to let go the transabdominal probe and look at this brain transvaginally. And luckily, this brain, the fetal head, was in the lower uterine pole, and you can produce pictures with remarkable detail, as you can see over here. And that is the cerebellar hypoplasia that you see. Now, the importance of doing a vaginal scan is that I can get direct, marvelous, very high resolution pictures of the direct mid-sagittal section. You will also agree with me that there is one lateral ventricle which looks a little bigger, the other lateral ventricle looks a little smaller. So when I go strict mid-sagittal, I'm not going to cut supratentorial mid-sagittal, I'll be cutting through the bigger ventricle, and that's exactly what has happened over here. You can see that I'm not showing you the midline structures because one of the ventricle has actually trespassed into the midline, and that is the ventricle that you see here. You find that there is very thin cortex. You find that the pericerebral space is really increased, and the posterior fossa has an additional finding. That's the vermis. This is the brainstem. You have the thalamus, you have the midbrain with its dorsal hump, and you have the pons. That's the brainstem. And the pons should have a distinct front, the anterior or ventral belly, a projection there, and that belly is clearly missing. So when I do an AP width of the pons, this is 4.7 millimeters. And if I look at the pontine charts at 19 weeks, this is 5th percentile. Therefore, not only there is a cerebellar hypoplasia, there is also a pontine hypoplasia. So there we have seen two scenarios now where there has been supratentorial findings in terms of a classical dysencephaly, in terms of a gross ventriculomegaly, but in both of them, the posterior fossa has been abnormal. When we encounter this kind of a combination, we need to understand that we might be dealing with pathology or abnormality in what is known as the tubulin set of genes. Tubulin genes code for tubulin proteins, which are fundamental components of microtubules. And microtubules are organelles, intracellular organelles, which are involved in intracellular transport, cell division, and in neuronal migration. So therefore, mutations in the tubulin genes can result in a spectrum of abnormalities termed tubulinopathies. And we have multiple genes which can cause tubulinopathy. I've just named 4 of them: TUB-A1A, TUB-A8, TUB-B2A, TUB-BB2B. All that doesn't matter. It just has to tell us that there are multiple tubulinopathy genes that we have to grapple with. Now, what does tubulinopathy mutation cause? It can cause problems in the cortical level as also the subcortical level. In the cortical level, it gives rise to leukencephaly or polymicrogyria like cortical dysplasia or a combination thereof. In the subcortical level, it can give rise to callosal abnormalities, a complete agenesis, partial agenesis of corpus callosum, or dysgenesis of corpus callosum, cerebellar or brainstem hypoplasia. So if you have supratentorial or cortical level problems, plus a corpus callosal level problem, plus a posterior fossa problem, and if there is microcephaly, that is a cocktail which should tell you that you are perhaps on the pursuit of a tubulopathy gene which is abnormal. Now, how does this translate postnatally? Microcephaly, developmental delays, spasticity, hypotonia, epilepsy, and this is again where a neuro consultant can translate these anatomical findings or genetic diagnosis into clinical symptomatology. And this is just to tell you 3 genes and what are the mutations which can give rise to the microlissencephaly group of disorders, lissencephaly group of disorders, or polymicrogyria group of disorders, all the 3 which can be manifestations of the tubulopathy genetic problems. Now, that we've realized that yes, we need to look at the corpus callosum carefully, we need to look at the posterior fossa carefully, and we need to consider tubulopathy genes as a totally different bag of genes which can be abnormal and which can wreak havoc in the fetus. Now let's move on to yet another scenario, and this scenario is a 30-year-old G2P1L1. This is a 12-week gestation. Now the first child is a male child, 4-year-old, microcephalic, seizures, mental retardation, low set years, and MRI talks of what the specialists call encephalomalacia and gliosis. The next-gen sequencing has revealed an L1-CAM hemizygous gene variation on the XQ. That's the long arm of the X, which is an X-linked recessive situation. Now, an LCAM gene mutation on the XQ is a recessive disorder which gives rise to what is known as an X-linked hydrocephalus. It's also known as X-linked complete agenesis of corpus callosum. It's also known as a massa syndrome because it has MR, it has adducted thumbs, a shuffling gait, and aphasia. We need to realize that L1-CAM gene, the abnormality is situated on the X chromosome and it's recessive. So therefore, if it is a female with an abnormal X, the other X dominates, the healthy X dominates, she becomes a carrier, right? So here is father who is normal and mother who is herself a carrier. The mother carries the abnormal gene there. So therefore, the first combination is that this could be a female carrier just like the mother. And this female carrier, once born, has a normal phenotype because the normal X suppresses the abnormal gene in the abnormal X that she has also got. Whereas if the father contributes the Y and the mother contributes the abnormal, the X which is carrying the L1-CAM gene, that is a male. And since there's no X to counter, you have a male who is affected. Similarly, this is a female which is unaffected, and this is a male which is unaffected. Therefore, half the female children progeny are going to be carriers, the other half of the females are going to be normal, and one half of the male progeny are going to be affected males, the other ones are unaffected. So this is why we call it hemizygous. It is recessive, but you don't need double dose. A single dose is enough for it to manifest, because if it is a male, there is no normal X to counter, and that is why you use the term hemizygous. And this is the report. Okay, so that was the L1-CAM diagnosed in the index child. And this is extremely important because a lot of times the index child workup becomes the starting point. here is a case example where it's 12 weeks. I have not found anything really spectacular in terms of pathology by imaging, but I know from history that yes, this couple has already had an X-linked recessive disorder in terms of an L1CAM gene problem which has affected the child. So therefore, since there is a genetic diagnosis in the index child, we offered a CBS and the patients agreed, the couple agreed, and that's the needle in situ. You can see that's the needle, that's the chorion that you see here, and that's the fetus, that's the amniotic fluid. And we sent it up for Sanger sequencing. Now your job is easy. You know what is the abnormal gene. You're not going to use NGS, you're going to use Sanger validation. And on the Sanger report, you find that the fetus of so-and-so, the relationship to the index patient is to be sibling, because it's a fetus, it's not yet a sibling. So it's to be sibling. You're looking for L1CAM gene on exon 19, and this is the variation which was reported in the index patient. I haven't shown you the report of the index patient, but simply this is what was reported. The variant is hemizygous and it is present, right? It's present, and therefore the clinical condition of the family member not known. So therefore, let's read this. The index patient, baby of so-and-so, presented with clinical indications of neonatal seizures, microcephaly, bilateral loci ears. The electroencephalogram was suggestive of independent S2 foci, blah, 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 right? But here, the MRI of the brain was suggestive of chronic infarct, and encephalomalacic changes, gliosis in the right temporoparietal lobe with hemocyanin staining along the gyri. Baby of so-and-so was found to harbor the hemizygous variant of the L1CAM gene and is being evaluated for the same. So therefore, the fetus now is proven to harbor the same L1CAM gene variant in the hemizygous dose, and therefore the fetus is affected, and this couple opted for a termination of pregnancy. So here, a known genetic cause, a known genetic diagnosis in the index child enabled prenatal diagnosis as early as 12 weeks, and that is the importance of workup. And that is the importance of workup prenatally, because it means there is a certain amount of recurrence chance if it's a recessive disorder, and therefore you can always offer a prenatal diagnosis well in advance instead of waiting until the sulcation gyration comes, which will take about 26 to 28 weeks. Now let's change tack and we will look at this case. A 28-year-old primate, 24 weeks gestational age, and she presents to you with echogenic lesions in the left ventricle. And such echogenic lesions in the left ventricle of the heart, this is not of the brain, but that of the heart, these are rhabdomyomata. And when the rhabdomyomata are present, you're worried about a condition called tuberous sclerosis, which also causes hematomata in the tubers in the intracranium. So therefore, more than the rhabdomyomata, we are worried about tuberous sclerosis, and therefore a fetal blood sampling. We did a fetal blood sampling for testing of TSC1 and TSC2 genes. Luckily, these are the two genes. Some conditions have a lot of genes, as what we saw in the lissencephaly case. But this is fairly straight and simple. Two genes, TSC1, TSC2, clinical exome sequencing done. There were no findings of tuberous sclerosis in the parents. So once you find a rhabdomyomata, we always look at the parents. We look for adenoma sebaceum. We look for astroid vacuoles. We look at their kidneys to look for angiomyolipomas. So none of these findings were forthcoming in the parents, and therefore this is the report. This is the report sampling clinical exome sequencing. Okay. Now look at the report. The report of the fetus says that there is a TSC2 gene mutation which is autosomal dominant, and this is pathogenic. Straight away, it is pathogenic. It's not one of the likely pathogenic or variants of unknown, straight pathogenic, and therefore the couple opted for a termination of pregnancy. So now this same question arises. where did this gene come from? The parents look clinically normal, but that isn't enough. So you need to do a Sanger analysis or Sanger validation for both the parents, the mother and the father. I've labeled it as mother and mother. One of them is male. This is male, so this is father. You read this as father, this is the mother. Both of them are normal, and therefore you know that this is not come from the mother or the father. It's a de novo mutation. So when they conceived the following year, we discussed this with the couple. They opted for no prenatal testing because there were nothing in terms of rhabdomyomata. There was nothing in terms of tubers. So therefore, at 24 weeks, we gave a clearance imaging-wise, and this couple really didn't opt for invasive diagnosis, and they went on to have a normal child. So when we tell them that, yes, this is a de novo mutation, you have very less chance of the same sporadic event occurring during gametogenesis, during the post-zygotic phase. They said they backed out of it. So lastly, I'm going to take you through another case. I think I'll skip this case because it's heavily imaging oriented, and I'm running off the time. I will just use the last 2 or 3 minutes to this is a slide which tells you the power of imaging, which tells you the amount of information you can get with ultrasound today. I'm going to skip this for the want of time, and that was a case of right hemimegalencephaly, periventricular heterotopia, right occipital thisencephaly, subarachnoid cyst, and sinus pericranii. And that's the genetic basis. We don't have time for this. And of course, when you think of single gene disorders, there are clearly 2 case scenarios. With a diagnosed index case, we saw one of that, and without an index case, we saw one of that as well. Now let's look at the last case before we do some question and answers. Here is a 29-year-old fetus, a 29-year-old mother, 19 weeks gestational age. She's a priming, and there is bilateral lateral ventriculomegaly. That is the lateral ventricle on one side, lateral ventricle on another side. 10 millimeters, more than 10 out there, and the CSP was a little small. At 19 weeks, yes, I wouldn't expect a great CSP, but I was really not happy in the sense that there was not even that not great CSP that I would expect to see. So naturally, you would want to see the brain fine, better, and you realize that this is a vertex presentation. Head is in the lower segment. You immediately switch to transvaginal ultrasound, do a full neurosonogram. That's the midline, mid-sagittal structure. You see the worm is there, the corpus callosum is present. You see the ventricle on one side, parasagittal. You see the coronals in the transcaudate plane and also in the transcerebellar plane. You don't expect sulcation at 19 weeks, so I'm not going to breathe a word about whether this is going to be normal sulcation-wise, but I know that there is no other problem which is there except for a very small CSP and ventriculomegaly. Now, the classical teaching in lateral ventriculomegaly, especially the mild lateral ventriculomegaly, is that you need to keep a chromosomal problem in mind. You need to rule out chromosomal abnormalities in addition to fetal infections, and you need to look at neuronal migration disorders. Now, for neuronal migration disorders, you need to wait. You need to wait for events to unfold until the fetus is about 26 weeks or 28 weeks. You have no shortcuts there. Whereas for infection, you can do a PCR on the amniotic fluid, or you can look at the torch, IgGs and IgMs of the mother. And of course, for chromosomes, you can do an invasive testing. You can take a bit of the amniotic fluid and look at the karyotype. So generally, what we do is karyotype to rule out any Down syndrome, so on and so forth. But in this case, we opted to do a chromosomal microarray, because we know that chromosomal microarray is a very, very refined form of karyotype. In the sense, it's so sensitive that it picks up the microdeletions, it picks up microduplications, and any increased complement or decreased complement in the chromosomal or genetic makeup is reflected. Now, when we did the chromosomal microarray, we stumbled upon a very, very unexpected diagnosis. And on high resolution chromosome array, there was a deletion, a micro deletion running into about 4,884 kb, which was present on the 11th chromosome short arm, 11p, and this was consistent with a syndrome called Vager syndrome. Now, what is Vager syndrome? Vager syndrome is Wilms tumor and iridia, genitourinary problems, MR, obesity. So all in all, this lateral ventriculomegaly was actually the tip of the iceberg, and we uncovered the problem this fetus would have had if it were to be born and it were and grow into a child. Now, we also have some literature which says that Vager syndrome is associated with ventriculomegaly, callosal and CSP defects, and we had a small CSP in our index case, and we also did see ventriculomegaly, right? So this is a random sporadic event. The sporadic rear microdeletion occurs in gametogenesis or during early embryonic development, and there's no increased risk of recurrence in the future pregnancies. This is important for counseling. This is important to fix a diagnosis in terms of a microdeletion. So most cases are a random event, low recurrence, but again, some of them can be a part of a balanced translocation. So therefore, when we sat and counseled, yes, they said they will not go for, in future pregnancies, they will not really plan for anything in terms of invasive diagnosis if the imaging is normal. So they went on to have another pregnancy, another baby where the ultrasound was normal, and that baby today is normal, right? So with this, I will just come to the concluding slide. So you need to take a good clinical history, no doubt about it. You need to dig out all the previous gene testing reports. If the index abnormal child is there, and if the index child is abnormal, it's never too late. You can work up the index child using CES or using next-gen sequencing, using whatever, and that is where a geneticist is extremely important. Having done that, potential for prenatal testing should be discussed, pre-test counseling, post-test counseling, or post-result counseling, and this is extremely intensive from a geneticist point of view. We need to tell them the turnaround time. The results, if they are ambiguous, we should also prepare them for that. And that is exactly where a geneticist really comes into the picture. We need to look at PCP and DT and its implications. And we need to look at the cost of the whole exercise. So it boils down to say that, yes, the obstetrician, the fetal medicine specialist, the geneticist, and the neurologist have to work in tandem to take this couple to as close a diagnosis as possible, and to see if we can extrapolate the diagnosis into the fetus and give them a prenatal diagnosis. So thank you very much for a very patient listening. Thank you, and we'll go on to slides. Can we take off this? Can we go on to the questions? Please take off the slides, and you can activate your webcam now. Okay. I have a question. What is third-degree consanguinity? Third-degree consanguinity is first cousin marriage. So if any of the parents of the husband and his wife are brothers and sisters, or sisters or brothers, that is third-degree consanguinity. So if one brother's son marries a sister's daughter, that is third-degree consanguinity. If there are two sisters and if their progeny marries, one boy and one girl, that's third-degree consanguinity. If there are two brothers and their progeny, the son of one brother and the daughter of the other brother marry, that's third-degree consanguinity. Uncle-niece is second-degree consanguinity, which means that the the husband has married his own elder sister's daughter. That is second-degree consanguinity, and first-degree consanguinity is incest. The progeny of the same parents who land up having progeny. Dr. Indumati is asked why scans were done at this gestational age, and that is a stroke of luck. That is a stroke of luck. I think Dr. Indumati is actually alluding to the first case which I said, where I said the 21 weeks case, or the 21 week scan was normal, and at 28 weeks there were so many findings which came through. That's pure luck. She was absolutely referred only for a repeat growth scan. That was pure luck because we had no clue in the 21 week scan. Dr. Sumati Natarajan, hi Dr. Sumati. How possible is it to suspect delayed sulcation during the second trimester anomaly scan? No shortcuts here, you cannot. Simply, to cut a long story short, TOP is permitted in India till 20 weeks. So we try to do our anomaly scans around 18 weeks, 19 weeks, or maximum 19 plus weeks or 20 weeks. By 20 weeks, there's absolutely no sulcation that has occurred in any fetus. That is how embryology, human embryology, has been programmed. So just because there's a TOP Act in our country, you cannot hasten embryology. You cannot tell this fetal brain, you develop fast, I want to give my results fast. Because we are in India, we are bound by a law. You have to wait for that 26 weeks. And then only you can look at those sulci and gyri. Now, the exceptions to this is a gross ventriculomegaly, or a very small cerebellum. So these are things which at 20 weeks itself are abnormal. But if it's pure agyria, pure classical lyssencephaly, where there's nothing else, you need to give that time to the fetus for those findings to actually appear. Dr. Malini, can an XX or XY diagnosis help in hemizygous X-linked recessive L1 CAM? If XX, they would be carriers. Certainly, yes. If it's XX, you don't need to do a prenatal at all because the maximum is it's going to be female carrier. If it's an XY, we are worried whether it's an affected boy or an unaffected boy. So therefore, if you're sure of sex, you can almost tell the couple that yes, you are sure of what's happening. You don't need to prenatally diagnose, but you have to get your documentation right because prenatal diagnosis is now governed by PCP and DT Act. For a long time, we all know that. But if you've got your documentation in order, all your genetic reports filed, there is no harm in looking at the perineum of the fetus. It is medically allowed. The Act does make provision for use of ultrasound or any other imaging technology to reveal the sex of the fetus. Dr. Manjit Mehta, as legal age for MTP in India is 20 weeks, what is the point of doing amniocentesis at 28 weeks on confirmation? What is the course of action? Now here we did an amniocentesis at 28 weeks and we landed up getting a diagnosis which told us that it is a sporadic event, a de novo mutation. So therefore, we are not going to really plumb and say that there is a very high recurrence rate like in a recessive condition. The next pregnancy, she's a primary, remember, she's going to plan for a family. So next pregnancy, when they are confronted with this being the situation, there is all chance that the couple might opt out of prenatal testing. So now this enables you to tell them that it's a de novo mutation, the recurrence rate is less, and that is how you work up an index case. You're no longer looking at the management of this case alone, you're looking at this case as what it means to her future pregnancies. I hope that answers your question, Dr. Manjit Mehta. Dr. Sumati, do you recommend amniocentesis for all mild ventriculomegaly? That's a good question. Now, why do we do amniocentesis? We need to look for the chromosomes. We were doing it with a classical karyotype, but now we have graduated, we tend to ask for a chromosomal microarray. Now, whether to do or not depends upon what was the first trimester combined test result. What was the maternal age? If it's a young lady, she's got a very low risk on the combined test. Example, 1 in 10,000 or 1 in a lakh, so on and so forth. The likelihood ratio for mild ventriculomegaly is in the order of about 3.8 if my memory is right. So say you round it off to 4. That means mild ventriculomegaly has made this lady 4 times high risk from her basic risk. So if she has a basic risk of 10,000, 4 times increased risk translates to 1 in 2,500, which is still in the parent's mind a low risk. So it all depends upon what was the combined risk. Is ventriculomegaly alone? Do you have other additional markers? Is there a pelviectasia? Is there an ecogenic focus? Is there an ecogenic bowel, which kind of tells you that the risk may be more? And of course, your counseling, the way you put it across to the patient, the parents can decide and say, yes, I'm going to opt for amniocentesis. No, I'm not going to opt for amniocentesis. But always we have to place the cards on the table. It's an indirect form of counseling. There is no question of saying you have to do it. No, it's up to them, because always there is a procedure-related loss, and we always give the choice to the parents. So Buhinakwi, first PTND baby expired after 45 days due to metabolic liver disease. At present, 12 weeks. Which test to be done? A classical scenario, although this is nothing concerned with the brain anomalies that we discussed a little while ago, I would say that a complete workup is important, and that is again the reason why we did an amniocentesis at 28 weeks, because that gave us a complete grip on the case. We don't have a complete diagnosis. This was a baby expired after 45 days due to metabolic liver disease. That's far too vague. I need to dig out the records. What are the metabolic liver diseases? Is it a storage disorder? Is it Gaucher's disorder? Is it an Niemann-Pick disorder? Was there any molecular workup that was done? Was there a liver biopsy that was done? What is the closest you can get to the index case diagnosis? Look at the genetic basis and then extrapolate it into the present pregnancy. So index case details, no shortcuts, you must have it. Mukherjee Kanchan Gmail, okay. Should we perform amniotic fluid CMA for all microventriculomegaly cases? I have started doing it. Because you don't know what case is going to pop up what. Remember, when you do a micro deletion, when you do a micro array, you don't have to worry about missing a certain deletion or missing a certain duplication, which chromosomal banding will not give you, a GEMSA banding will not give you. So therefore, you're doing an amniotic fluid, do a microarray, do a chromosomal microarray. So that will give you a wider coverage. Availability is a problem, but now you can zip samples across and get your samples assessed. But remember, if you're doing a microarray, you better route your couple through the geneticist. I don't know what specialty you belong to. If you're a fetal medicine person, a basic fetal medicine person, not a geneticist, sometimes interpretation of these reports can be a challenge. So I think they should have a pre-test counseling through a geneticist, then submit the sample through the geneticist to whichever lab and get your geneticist to interpret the post-result test as well. Right? First, PTND baby expired. That we finished. Should be for what was the genetic report? MCD with one? No, that lady didn't agree. Both the cases I showed you, I thought of tubulinopathies, but then they said no. It's up to them. We lay the cards on the table. Some of them will say, no, I will not. I will come back to you for a scan. I'm not going to do genetic testing. It's up to them. I don't know. I don't know what is the genetic report because they simply walked out of the test. Sir, which book? Veer. Sir, which book do you recommend for fetal neurosonography and basic genetic book for obstetricians doing ultrasound? A basic genetic book for ultrasound, doing ultrasound. there are a lot of basic books. You have to read and understand what is dominant and recessive. You need to, a lot of fetal medicine conferences, we have geneticists who are extremely, extremely good today. I mean, they are so good, it baffles you how they crunch the genes and they crunch the chromosomes, so on and so forth. You need to listen to them, and a lot of things become very clear. But the best way to learn it is to see what a pedigree chart is. Look at your geneticist's work and then learn from. You can never ever replace a geneticist when however much you learn, but the advantage is that you will be able to talk to your geneticist one-on-one as a fetal medicine person if you know the genetic background. And that's extremely, extremely important. Are we running out of time, or can I take the last 3 questions? Okay, yeah. Dr. Renu, how do you say it's ambiguous genitalia on ultrasound out of purview for this? I need to show you with visuals. I need to take you through my lecture on ambiguous genitalia. Dr. Dhaval Gorasia, how do you differentiate between Vermian hypoplasia, black pouch cyst? Blake's pouch cyst is the mixed sagittal section. A Vermian hypoplasia has a small vermis, so your vermis, in terms of its length, in terms of its AP thickness, is smaller than what you expect for gestational age. So you have to have a mid-sagittal section, a good Vermian picture on the mid-sagittal section. You should have charts to say that this is less than 5th centile, and also you should visualize the brainstem and also show that this vermis is rotated away from the brainstem. That is Vermian hypoplasia. In Blake's pouch cyst, the vermis essentially is normal in terms of its shape, in terms of its size. So that kidney bean looks normal, but it's only rotated away from the brainstem. So pure rotation with the size and shape normal, that is a Blake's pouch cyst. Good outcome. Whereas rotation with a vermis which is small, lumpy, doesn't look like the kidney bean shape, doesn't have a fastigium, doesn't have a primary fissure, and whose size is less than 5th centile, both in terms of AP, in terms of cephalocaudal, that is Vermian hypoplasia, which has a guarded prognosis. Again, Dr. Dhaval Gorasia, what is more important, Vermian size or BV angle? It's a combination of both, and just now I have told you. The degree of rotation in Blake's pouch cyst is a little less, the degree of rotation is a little more, and that's where your brainstem Vermian angle will help. But believe me, more than the angle, look at the morphology of the vermis. If it is good, normal kidney bean, Blake pouch cyst. If it's not, if it's looking abnormal, that is more likely to be a Vermian hypoplasia. Right? I think I've answered all the questions. I've overshot by about 5 minutes. And I hope this exercise was useful to you. And it's only to say that imaging doesn't stop at imaging. You have to graduate into being a part geneticist, a part neuro consultant, a part pathologist, also perhaps to actually look at this case in a holistic manner. And you should interact cross-speciality, and we should translate these findings into a language, into a form which the couple can understand. Not all couples are medical couples. So into a layman's language is what we need to do. Thank you very, very much, and wish you all the very best, and I sign off.